त्वं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदः.
Sir, I welcome Dr. Durgadar sir for his few words about our webinar series. Welcome, sir.
Good evening, everybody. Thank you, Dr. Shilpa, for the opportunity given. At the outset, I congratulate Dr. Shilpa Harish for this wonderful webinar. You're doing excellent work. Your flyers regarding the short flyers you are sending for infertility is really handy for the newly practicing obstetricians. It's very informative, very crisp. This is the first time I'm seeing this type of literatures, so sweet, so compiled. So, and this is their second achievement with respect to webinar. I really congratulate you. And the theme you have chosen, endometriosis and reproductive health beyond pain. Very good topic and very good speakers. My friend Dr. Prashant Adiga and Dr. Radha Vembu, they are talking on medical and surgical management. And the panel you have chosen is fertility treatment in endometriosis, going to be moderated by Dr. Basuraj Devarashetty and Dr. Chandana Bhatt and Dr. Vandana Mishra as the expert. The panelists Lavanya Kiran, Vidya, Sujay, Swapna and Shrija. Everybody, I congratulate you for participation. One word about the webinar. See, I'm seeing so much of work you have done. Only 17 logging ins. It's really, it's not up to the mark. I request we have to do something for this. At least ask your colleagues from BSOG or from Sir Gangavati or Manipal. You have so many PGs in your belt. Like Prashant Adiga is having wonderful PGs team. And your colleagues, you see that at least we touch 100, though not 100, at least we have to cross 50 and 60. You are putting effort, so much of effort you are putting on the subject, on the scientific activity, whom to call, who are the experts, choosing the best topic and all. I think a extra step of how to increase the number of participants. Try to have a goal of around 100. At least you can go up to around crossing 50, 60. It's a wonderful topic you have selected. With this suggestion, I don't want to talk anything else. All the best, Dr. Shilpa, for your webinar. And next time onwards, not only for you, for all the committee members, you are doing wonderful job. And see that the logging ins will be increased. And you convey this to each and everybody. Like other day, Rajagiri's talk was there. It has not crossed 100. In his first talk was he has touched 250. At least you tell your colleagues, PGs, in some way, we have to see that it crosses 100. With these few words, once again, congratulations to Dr. Shilpa and the whole team. Thank you.
Thank you, sir. Now I hand over the stage to Dr. Chandana for further proceedings.
Thank you, ma'am. So now we have...
we also have Dr. Priyanka around. She is also a panelist.
Yes. So now we have two talks by two renowned speakers, Dr. Prashant Adiga and Dr. Radha Vembu, for which I request Dr. Shilpa Harish to chair the session. So Dr. Shilpa Harish, she is a senior consultant IVF specialist at Satwam Fertility and IVF Center. She is the ART chairperson of Kasoga 2025-2027. I kindly request you to introduce the speakers and start the session.
I introduce Dr. Prashant K. Adiga. Sir is professor and head of the Department of Reproductive Medicine and Surgery, KMC Manipal. He's got Imaging Science Award in the year 2007, Fellowship in Advanced Obstetrics and Gynecology at Mediscan Chennai 2007, Fellowship in Reproductive Medicine and Surgery at KMC Manipal, has many national and international publications, has contributed for chapters in various textbooks. I introduce our next speaker, Dr. Radha Vembu. Madam is MBBS DGU DNB, PhD, DNB FICS FICOG, Professor and Head of Reproductive Medicine and Surgery, SRMC, SRI, Srihar. PhD, Madam has done PhD in the field of Reproductive Medicine and Surgery, Joint Secretary TAPISAR 2022-24, Secretary of TAPISAR 24-26, has various national, international papers and publications, postgraduate examiner in various universities, invited speaker in various national and international conferences. Her awards are A.L. Muralidhar Traveling Fellowship Award, Best Paper Award in IFFS World Congress 2015, Young Fellowship Research Grant Award, Sri Ramachandra University, Isar Dronacharya Award 2023-2025. Welcome, sir. Welcome, ma'am. Can we have our first talk, Dr. Chandana?
Yes, ma'am. Now I request Prashant sir to kindly share his screen.
Are my slides visible?
Yes, sir, it's visible. You can just put it on the slideshow mode.
Yeah, I put it on slideshow as well.
Yes.
Okay. Thank you for those kind words. Good evening, everybody. Today I'll be talking to you about medical management of endometriosis, the pain aspect. And this is something which we see day in and day out in our OPD. First, greetings from the temple town of Udupi. That is the idol of Lord Krishna, which is about 800 years old. And this is our university, which is almost about 80 years old. So this will be the timeline through which I'll be talking. Now, we all know that endometriosis is a disease where we find that the endometrium is outside the uterine cavity. Most of the times it is within the pelvis, but sometimes it can go beyond the pelvis into the abdomen and various other sites. And the unfortunate thing is that in India, 42 million girls and women of reproductive age group are affected in India. And the care which we give probably is suboptimal because many times patients may not have access to the healthcare system, or probably some of the doctors may not be aware of such condition called as endometriosis. So now, if you look at this is a study where they have found out the impact of this pain. So look at this educational attainment. Yes, they may have difficulty. There might be regular absenteeism. Employment and career. Nowadays, if you don't attend regularly, you are fired. Okay. Again, pain can have an impact. Social life, and of course, family life. See, they manifest in the form of infertility, where again there is a lot of hopes from the other members, and of course, personal relationship. It might be because of emotional distress. And the most important point, which in India, unfortunately, we do not cater too much, is the mental health, which in the Western world has a lot of importance. And of course, the quality of life. These are some of the important aspects where the pain can have a significant impact. So by reducing the pain, can we make their life better? So let us see. There are 7. Usually, my mentor, Dr. Pratap, would say 5 Ds of endometriosis. But I would say that there are 7 Ds. This is for postgraduates. One is dysmenorrhea, which is very easy to remember. Dyspareunia, deep-seated pelvic pain, dyschiasia, disorders of menstruation, maybe in the form of menorrhagia or polymenorrhea, difficulty in conceiving, nothing but infertility, and delay in diagnosis. Unfortunately, this delay in diagnosis, the time taken from the onset of symptoms for the diagnosis is as high as 7 years. That means imagine that the patient has to undergo, especially adolescent girl, where she may be told that she is malingering. Okay, when you do a scan and if you find that there is superficial peritoneal endometriosis, and in an adolescent girl, transvaginal ultrasound may not be done, but a transabdominal ultrasound will not give optimal pictures, and the diagnosis that she is malingering or she has got some psychiatric illness is there. And of course, these are the symptoms. Signs being uterus will be retroverted, there will be tenderness in the fornix, right? Fixed retroversion, diagnosis of endometriosis is made. And the most important aspect, which I would like to tell you, symptoms and signs do not correlate with the severity of disease. A person having mild disease may have severe pain, and vice versa. A patient having severe grade of endometriosis may not have any pain. So the clinical features do not correlate with the staging of the disease, in other terms. And which are the common sites? We all know the ovaries and the fallopian tubes, the pouch of Douglas, the uterosacral ligaments, then the rectovaginal septum, and the peritoneum. And you have three types of endometriosis classification: anatomical, superficial peritoneal endometriosis. Then you have the ovarian endometrioma, which is very easy to diagnose, and deep infiltrating endometriosis, where you need to concentrate on the transvaginally to look for the rectovaginal septum, where you will be seeing hypoechoic nodules. Then coming on to theories, we have been seeing the various we are used to listening to the various theories. That is the retrograde menstrual theory, where this can explain about the nature, the location. Most of the times, the most dependent portion, that is the uterosacrals and the pouch of Douglas, is involved. So this retrograde menstruation theory does hold good. Then you have something called as the hematogenous and lymphovascular dissemination theory. This can explain to us about the extraperitoneal locations, like, for example, the scar endometriosis. Then the stem cell theory, yes, the peritoneal and extraperitoneal location. Basically, what they say is that the basal layer of the endometrium has got a lot of stem cells, and during the retrograde menstruation, these stem cells are relocated into the peritoneal cavity, and they have the totipotent nature, and they can get converted to any of the desired tissues they would like. Then, of course, you have the coelomic metaplasia theory, and now you have the epigenetic theory, where there are a lot of epigenetic changes related to food and the water and the air we take, and not to forget the new concept now of the gut microbiome theory. And I will not go into details because there are a lot of articles once you type it in Google Scholar. Now, why do patients with endometriosis have pain? This is a very interesting slide. Now, if you look at this slide, now, whenever there is retrograde menstruation, I told you that menstruation is an inflammatory process. There will be a lot of inflammatory cells, and these endometrial fragments, they will have these inflammatory cells. They are translocated into the peritoneal cavity. And remember that these patients are more prone, patients who have got this, they are more prone to develop endometriosis. They have, see, basically these fragments have a scavenging system. So in patients who are prone to develop endometriosis, there is altered immune mechanism, because of which these endometriotic or these fragments are not scavenged, because of which they get implanted. And I told you there is inflammation. So this inflammation will result in what is known as neuroangiogenesis. That means they are going to give blood supply to these endometrial implants. And secondly is that they become pain sensitive. So every time the patient bleeds, then these nerve endings are stimulated. So if you look at this, it is very obvious here. And of course, the second thing what happens is there is peripheral sensitization. This neuroangiogenesis, what happens is basically they are C fibers, C delta fibers. They are very, very pain sensitive, and they are going to carry this afferent sensation to the brain through the spinal cord. And there is something called as cross-sensitization. What do you mean by cross-sensitization? All the nerves from the colon, from the bladder and the genital tract, they converge in the dorsal root ganglion, because of which there will be some, what is a referred pain. So because of which patients with endometriosis can have dysuria, they can have irritable bowel-like syndrome. And lastly, but not the least, is central sensitization. That is, these patients have a lower threshold for pain, unlike a normal person. So it is important that you adequate pain relief for these patients. I hope I'm audible.
Yes, sir. You're
Thank
audible.
you. Yeah.
Yes, sir.
So central sensitization. Now the effect of this chronic pelvic pain is that the gray matter in patients with chronic pelvic pain may reduce. So it is important. It is not related to, but in general, chronic pelvic pain patients do have a reduced gray matter. Now, a few words about progesterone resistance. Many times you find that you have started the patient on progesterones. Initially, they respond, but later on, the patient comes and says, "Doctor, I'm not very happy with the response or with the tablets you have given." So that is basically because of the progesterone resistance. Now, why does progesterone resistance occur? Now, remember that the causative hormone for endometriosis is estrogens. Now, basically, there is increased aromatase activity, because of which the estradiol levels are high, and the breakdown of estradiol is also impaired because there is altered 17 beta hydroxysteroid dehydrogenase. Now, remember that the 17 beta hydroxysteroid dehydrogenase, it inactivates estrogen basically. So the net result is that there is increased estrogen concentration. We all know that endometriosis is a hyperestrogenic conditions. The effect of these estrogens, increased estrogen, is one, there is decreased the progesterone receptors. Now, progesterone receptors are mediated through what is known as estrogen receptor alpha. Now, in patients with endometriosis, there is downregulation of this estrogen receptor alpha, because of which the progesterone receptor expression is on the lower side, and these patients can have progesterone resistance. And not the least is about this adolescent endometriosis. Many times you find that there is neonatal uterine bleeding. Now, neonatal uterine bleeding is a risk factor for adolescent endometriosis. Now,
Sir, your slides are not seen for last 3-4 minutes.
is it?
Yes, sir.
So we are able to see your slides.
Now we can see. We can see. Few of
Okay.
us could not see.
Because
Sorry for interruption.
sorry.
Sorry for interruption. Few of
No,
us
no,
could
no, no.
not see.
I'm glad that you are told, because there is a lot of because of the heavy rains this time. There is a lot of internet variation. I'll just see. I think again internet. I'll just log in, madam. Sorry for the inconvenience.
No, I can see now. Thank you. I can see.
You can start, Prashant.
No, because the moment I think there is some internet problem. I'll switch off my camera. That will help. Because 1 minute, please.
Prashant, it is visible. You can start.
Okay, is it visible?
Yeah.
Visible, sir.
Okay, I was talking about the pain. Okay, shall I start from here or should I go back to the? Where
Start.
do you think I should
Continue.
start from?
Continue.
Okay, so progesterone resistance in patients with adolescent endometriosis, especially they have a risk factor of neonatal uterine bleeding. So remember that these cells, these endometrial cells, when they are shed, some amount of them will go into the peritoneal cavity and they are resistant to the action of progesterone. So adolescent endometriosis is less likely to respond to your progestin therapy. So basically, there are many factors which are responsible for progesterone resistance. One is the epigenetic changes, hormonal imbalance, signaling, and then receptors. Now, coming on to the drugs used in medical management of endometriosis. Now, if you look at the guidelines, the ESHRE guidelines, they say that there is the medical management for endometriosis only for pain relief. There is hardly any medical management for infertility. So, but since today my talk is on medical management of endometriosis related to pain, I'll be sticking on to this particular topic. Now, this is the timeline. So, in 1960s, they were using combined oral contraceptive pills using mestranol and norethindrone. Then in 1970s, they started using medroxyprogesterone acetate. Then 1990s, we got the agonists. And in the 2000s, we started using LNG IUDs and SERMs and sperms. Then 2010s, GnRH antagonists were used. And now you have many other cannabis and other which are in the experimental stage. So, is my slides moving, Dr. Basaraj?
Yeah.
Yes.
Now, when you talk about medical management, now the drugs which we use for medical management, either they inhibit the release of FSH and LH, indirectly inhibiting the synthesis of estrogen, or they might act on the estrogen receptors and prevent the action of estrogens. Okay, these are commonly used drugs. Now, according to the ESHRE, combined oral contraceptive pills and NSAIDs are the first line of treatment, along with progesterones. Then you have the agonists and the antagonists, which are the second line. And you have the aromatase inhibitors like letrozole and anistrozole, which are used as third line of treatment. So basically, it's the same thing. Now, combined hormonal contraceptive pills. Now, what does the ESHRE say? It says that it is recommended to prescribe a woman combined hormonal contraceptive pills. It might be vaginal ring, oral, or transdermal to reduce the endometriosis-associated dyspareunia, dysmenorrhea, and non-menstrual pelvic pain. So, women suffering from endometriosis-associated dysmenorrhea can be offered the continuous use of a combined hormonal contraceptive pill. So there is a saying that a woman should have about 4 menstrual cycles in a year. By minimizing the number of menstrual cycles, you are trying to reduce the pain, you are trying to halt the progress of the endometriosis. Then coming on to progestins, these are well-tested medications. You have medroxyprogesterone acetate. You can use 10 milligrams TID, maximum of 100 milligrams. They have studied until 100 milligrams for 6 months. And improvement of pain is noted in 80% of the cases. Norethindrone, 5 milligrams per day, maximum dose of 15 milligrams for 6 months. DMPA. DMPA is one wonderful drug which is cheap, which is effective. Every 3 months, 2 to 3 months, you can give 150 milligrams. And it is called as a poor man's leuprolide or GnRH agonist. It is as effective as leuprolide and danazol. Then medroxyprogesterone acetate. Again, subcutaneous, you have got subcutaneous preparation, 104 milligrams every 12 to 14 weeks. And again, it is comparable to GnRH agonist. Now, most of these DMPA and medroxyprogesterone acetate were used as contraceptives, and the non-contraceptive benefits of these are noted in endometriosis patients. Then LNG-IUS, fantastic drug, especially if the patient is not very keen on fertility. It is, again, whenever you these patients can have breakthrough bleeding, which can be, again, sometimes it might be a problematic case, but overall it is as good as a GnRH agonist. Then Dynogest, yes, we have got experience with Dynogest, 2 milligrams per day, and it can be, we have data till 60 months, that is almost 5 years. Again, it can be comparable to GnRH agonist. Then etonorgestrel implants, again, it is the off-label use. The company does not recommend this for use of endometriosis, but people have been using it with good results. Now, the side effects, we all know: weight gain, decreased libido, fluid retention. Then with 4th-generation progestins like Dynogest, there is a theoretical risk of deep vein thrombosis. That has to be kept in mind. Then what does the ESHRE say? It is recommended to prescribe women progestogens to reduce endometriosis-related pain. We need to consider the different side effects profiles of progesterone into account when prescribing them. And it is recommended to prescribe women LNG-IUS or an etonogestrel-releasing subdermal implant to reduce the endometriosis-associated pain. One point which we need to remember is when the patient is on progestins for a very, very long time, they can have mood swings. It is always important for us to ask whether she has any mood swings. That is something which we fail, but there's a good practice point that we need to ask about this. Then coming on to GnRH agonists, you have leuprolide 3.75 milligrams monthly or 11.25 milligrams every 3 monthly. Its action is similar or comparable to DMPA. Then goserelin is there, 3.6 milligrams monthly for 6 months. It is more effective than oral contraceptive pills. Then naferlin, easy to use, one spray twice a day, and the action is similar to medroxyprogesterone estate. Now, the problem with this is change in lipid profile, depression, hot flushes, bone loss, and urogenital atrophy. If you are continuing these patients with agonists for beyond 6 months, it is important that you add back therapy in the form of estriol valerate 1 milligram with norethindrone. So what does the ESHRE say? The ESHRE says that it is important to prescribe women GnRH agonists to reduce endometriosis-associated pain, although the evidence is limited regarding the dosage or the duration of treatment. And remember that these GnRH agonists should be used as the second line of treatment because of their safety profile. Okay, and if you are continuing more than 6 months, or if the patient has any hypoestrogenic symptoms, you need to add back therapy. Then coming on to aromatase inhibitors. Now, letrozole, 2.5 milligrams once a day for 6 months. It is effective alone, but it is better that you combine letrozole with some other medication, maybe progestins or GnRH agonist or antagonist, or even LNG-IUS. Then anastrozole, it is 1 milligram per day for 6 months and longer disease-free interval when compared with goserelin alone. Okay, so these are good, but these should be used in combination, and it should be used as the second or the third line of drug. Now, what does the ESHRE says? In women with endometriosis-associated pain refractory to the other medical or surgical treatment, it is recommended to prescribe aromatase inhibitors as they reduce endometriosis-associated pain. Aromatase inhibitors may be prescribed in combination with OC pills, progestins, or agonists, or the antagonists. Then coming on to the new molecule, the GnRH antagonist, you have got elagolix. Elagolix is a new molecule which is there for the past 6 to 8 months. It is basically, it is a competitively, it inhibits the receptors in the hypothalamus and the pituitary, because of which there is improper or there is no GnRH signal. We all know that the GnRH has to be secreted in a pulsatile fashion, because of which the FSH and LH will be secreted. That will act upon the the ovaries, the follicle, to release the estradiol. So basically, there is rapid suppression of LH and FSH. It is dose-dependent decrease in serum estradiol concentration. Then there is hypoestrogenic state, which will result in the reduction in the endometriotic lesion. Now, this is the dosage. If it is severe, you start with 200 milligrams BD, and then over a period of 3 months, you assess the patient's symptoms and try to reduce the dose. So my take is after you start initially with 200 milligrams twice a day. After 3 months, you can reassess. You can reduce it to 200 OD or 200 BD alternatively. So and then try to maintain the least minimal possible dose for a effective treatment. So in case the patient has mild pain, you can start with 150 milligrams a day. Now this is important because now if the estradiol concentration is between 30 and 60 picograms per ml, then it is in the physiological range. Anything less than 30, it is going to cause bone loss, or anything beyond 70, it is going to again activate the endometriotic lesions. So partial suppression of estradiol within the 30 to 60 picogram per ml range could be the optimal levels between efficacy, tolerance, and safety. Now, if you look at the elagolix at the dose of 150 milligrams, so the median estradiol concentration is about 42 picograms per ml, which is very good. On the contrary, if you start the dose at 200 milligrams BD, then your median estradiol concentration is 12 picograms, which can result in loss of bone mineral density. That is the reason why we need to reassess after 3 months. So contraindication being pregnancy, osteoporosis, severe hepatic impairment, and if you are using any of these enzyme inducers like cyclosporine and gemfibrozil, please don't give it along with it. Side effects being hypoestrogenic effects, then alteration in bone mineral density, alteration in lipid profile, then headache, insomnia, mood swings. These are the common things. Headache, insomnia, and mood swings secondary to hypoestrogenic states. Now, what does yesterday says? It can be considered to prescribe women GnRH antagonists to reduce the endometriosis pain, although evidence is limited regarding the dosage and duration. So this should be used as second line, not as the first line, where your progestins or the COCs have failed. Then which are the other drugs which can be used? Mifepristone 50 milligrams per day for 6 months, effective in reducing pain. It has its own set of problems like dizziness, abdominal pain, cramps. Then pentoxephalin, they have tried 800 milligrams per day for 3 to 12 months. It is no better than a placebo. The problem being dizziness and nausea.
Sir, another 2 minutes.
Yeah. Cabergoline, 0.5 milligrams twice a week. This I have used. Fantastic drug. There is a significant reduction in pain score compared to Dynogest. There is a reduction in the size, and it has its own problems like headache and drowsiness. Simvastatin, 20 milligrams per day per oral, 4 months. Again, comparable to GnRH agonist and muscle pain. These are some of the side effects. Now, infertility. Infertile women with endometriosis, clinicians should not prescribe any drug which suppress the ovulation. So basically, I want to tell you is there is no place for medical management in endometriosis-associated infertility. Those women who cannot attempt to decide or who do not want to conceive immediately after surgery may be given this hormonal therapy to suppress the progression of the disease. So there is a medical management in revised ASRM stage 1 and stage 2 endometriosis, where you can try ovulation induction with IUI. The role of medical management in stage 3 and stage 4 is in those patients where tubes are patent is uncertain. To conclude, endometriosis is a disease from menarche to menopause. There are 7 Ds like dysmenorrhea, dyspareunia, dysgeusia, deep-seated pelvic pain, disorders of menstruation, and difficulty in conception. Medical management in endometriosis is predominantly for pain. Progesterone resistance is noted in endometriosis. First line of drugs include NSAIDs and progestins. Second line being GnRH agonists and antagonists. Elagolix is a new drug for pain relief in endometriosis. Medical management of infertility associated endometriosis is for stage 1 and stage 2 disease. Thank you.
Thank you,
Sorry
Dr.
for the delay.
Prashant. That was a wonderful talk, starting from basics to pathogenesis and newer molecules in the management of endometriosis. Your emphasis of medical management in the management of pain compared to infertility was a good message for all the practitioners. Thanks a lot, sir. We
Thank
were
you.
honored to have you for
Thank
this.
you.
Thank
Thank
you.
you.
So I welcome our next speaker, Dr. Radha Vembu. Madam is HOD of Reproductive Medicine and Surgery, SRMC, Chennai. Madam, can we have your screen here?
Yeah, I thank KSOGA for giving me this opportunity. I'm sharing my slide. Is it visible?
Yes, ma'am. Yes, ma'am.
Yeah. Okay. So today I'm going to talk on the impact of surgical management of endometriosis in infertility. So we know this is a chronic inflammatory condition characterized by presence of endometrial glands and stroma outside the uterine cavity, mostly in the pelvic compartment. It's a chronic condition which affects 10% of the women in the reproductive age group. So of them, 17 to 44%, they can develop endometrioma. And among infertile women, 50% of them are infertile. So various things have been highlighted about the theories. Now, I just wanted to share a few thoughts about how endometriosis is causing infertility. One is by reducing the ovarian reserve. There can be anatomical distortion through fibrosis. They also create a pro-inflammatory environment. So how it affects the ovarian reserve is by increasing the concentration of free iron, ROS, and the pro-inflammatory cytokines. And there'll be stromal fibrosis with ROS, so they can impair the follicular nutrition and density, and it can decrease the follicular count. Now, if there is an endometrioma, so how does it affect the ovarian reserve? There is hypoperfusion and ischemia. So there is decrease in the response to gonadotropins, and there is decrease in the follicular growth. And they can also cause mechanical pressure, which prevents the follicles from reaching a diameter of 18 millimeters. So in turn, they decrease the growth of the follicles. So, and the other thing we talked about is the anatomical distortion through fibrosis. So there is alteration in the tubo-ovarian relationship, which is very, very important. So when we are doing a laparoscopy or any other, or even a simple ultrasound, we should see whether the sliding sign is present. All this we talk about because the tubo-ovarian relationship should be maintained for fertility. So in these patients, it can be altered, and the endometrial receptivity can also be affected by the dysregulation of the signaling pathways, endometrial stromal cells, differential gene expressions, vascular abnormalities, and all this, they can disrupt the implantation and trophoblastic invasion, and there is a pro-inflammatory environment. So what is this is, there is a chronic inflammation. So the peritoneal fluid has more of these immune cells than NK cells, the macrophages, and the T cells. So they, and also it can affect there is cytokines and chemokines which can interfere with the neovascularization, and there is fibrous tissue formation. So that can lead on to adhesions and pain. They also have an effect on the embryo oocyte and the embryo quality, and they impair the ovarian function. So folliculogenesis is affected and fertilization is also affected. So this we have to have in mind before we decide what should be the line of treatment. So overall, it has an effect on the ovulation. There can be abnormal folliculogenesis, decrease in the cohort of follicles, poor oocyte quality, decreased fertilization rate, low-grade embryo formation. There can be reduced implantation, luteal phase defect, and luteal unruptured follicle syndrome. So the most common modality of diagnosis is by the transvaginal ultrasound, where we follow the IDEA group recommendations, where they recommend a 4-step sonographic protocol for evaluation of the suspected endometriosis. One is the ultrasound feature of an endometrioma, the soft markers of endometriosis, and there can be dynamic assessment of the pouch of Douglas, where we can demonstrate the sliding sign, and assessment for the deep nodules in the anterior and the posterior compartment. So coming to the management strategies, yes, we have to tailor it according to the individual's, the patient presentation, symptoms, and the reproductive goals. So what is the need of the hour is an individualization, evidence-based approach, and we should balance the symptom relief, reproductive goals, and long-term ovarian health. This should be kept in mind when we are planning for the treatment modalities. Of course, there is lack of consensus, but there are some guidelines which we will be seeing in the few slides. Now, the options we all know is the expectant, medical, and the surgical management. So just a word, when we can plan for an expectant management is when the patient is very young and the cyst is less than 4 centimeters. If it is unilateral with the classic features of endometriosis, which can be a ground glass echogenicity, lack of papillary projections, and there is no suspicion of malignancy, and there is no family history of ovarian cancer. Now, always there is a dilemma whether we should go for a surgery or for an ART in patients with endometriosis. So why we are talking about this is we should know, before we know what is the impact, we should know what are the various surgeries, when we should go for surgery or when we should go for an ART. Now, the surgical management is indicated mainly in young age group who have a lot of time for natural conception. They have a shorter duration of infertility. The reserve is good and they are symptomatic patients. So if they are not symptomatic, better not to go for a surgical management. And if the natural conception is possible, that means the tube should be patent and the male factor should be normal. And on ultrasound, if there is a hydrosalpinx or a large endometrioma, that may warrant a surgical intervention. So the surgical response, management is also indicated when there is no response to medical line of treatment. And if we are planning for an ART, if there is a difficulty in accessing the follicles, so in patients with infertility and the ovarian endometrioma, many of the literature says more than 3 centimeters, but the latest HRA recommendation does not give any mandatory criteria for the size of the system for surgery. And if there is a non-reassuring sonographic features, or if the cyst is growing rapidly, when there is a suspicion of malignancy on ultrasound, or if there is a bowel nodule which can lead on to stenosis of the intestinal lumen and occlusive symptoms, or if there is a urethral stenosis which can be due to endometriosis and be leading on to hydronephrosis. These are the conditions which warrants surgical management. So there are various techniques for surgeries that for endometriosis. If there is an endometrioma, the options are cystectomy, electrocoagulation, or the laser ablation, the plasma energy ablation, and combined techniques. And the HRA recommends the stripping technique over all the other modalities because there is low rate of recurrence and the better fecundity. But the concern is when we are stripping the tissue, it may lead to inadvertent removal of the healthy ovarian tissue, which can decrease the ovarian reserve. So the surgical approach, if there is an endometrioma, is the simple the drainage and coagulation to ovarian cystectomy to oophorectomy. These are the various options, but lap ovarian cystectomy remains the gold standard for symptomatic endometriomas, which offers a histological diagnosis, pain relief, and also improves the fertility outcome. And the recent evidence says that it has a detrimental effect on the ovarian reserve. So the recent trend is shift towards a more conservative approaches of expectant management, medical management for a shorter duration, if not keen for fertility, the ablation and the sclerotherapy. Now, the HRA recommends that the clinician should counsel the patient with a ovarian endometrioma regarding the risks of reduced ovarian function after surgery, and the damage to the ovarian reserve is more severe in women who are treated for bilateral ovarian endometriomas when compared to the unilateral procedures. Now, the other option is the sclerotherapy, where ultrasound-guided aspiration of an endometriotic cyst and a sclerosing agent is injected. So here we can see in the first figure that there is a big endometrioma, which is aspirated, ultrasound guided, and a sclerosing agent like an ethanol can be injected. And 6 months later, we can see that there is a considerable regression. But one thing we should keep in mind is there are chances of recurrence, which is very high. So when we compare the expectant and surgical management, both have got both the pros and cons. So if we are going for an expectant management, we are able to avoid the surgery, and the compromise on the ovarian reserve can be reduced. And there's a delay in commencing the assisted reproductive technology. And the harms, we know that the symptoms, they persist. There are chances of having a spontaneous rupture, infection, and we don't have a clear-cut histological diagnosis. Whereas if we are going for a surgical treatment, they are relieved of the symptoms, and the other complications, what we talked about, the infection, cyst, or other complications are less. But we should remember that the surgical risks are there, and there is a compromise in the ovarian reserve, and post-operatively there can be adhesion formation, and there is a increased chances of delay in going in for an ART technique. Now, does the size of endometrioma matter? Because there are various literature which says that the number of oocytes retrieved from the ovary with the endometrioma less than 3 centimeters is similar to a contralateral healthy ovary. So this is another article where they have studied based on the different sizes of the endometrioma. They have divided into groups, and they have studied the number of oocytes retrieved in all the groups, and they found that there was no significant difference in the number of oocytes retrieved, the cumulative pregnancy rate, number of cycles cancelled, or the perinatal outcome. So this study suggests that the ovarian stimulation can be of benefit to women irrespective of the endometrioma size, and it is not going to compromise the outcome. So this is as per the ESHRE guidelines. Initially, they gave a cutoff value of 3 centimeter, but now there is no indication on mandatory for a mandatory surgery with respect to the cyst diameter. Whereas the other guidelines like the ASRM, they gave the cutoff as 4 millimeters. NICE guidelines says recommend cystectomy for all women, and the older guidelines like the ACOG, ASOGC, they were also in favor of surgical management. But now we understand the complications of surgical management, so we as far as possible, we try to avoid the surgery on these patients. Now, coming to the effect of this endometriomas or the endometriosis on the ART outcome. So this is a study in 2022 where they have studied the endometrioma and its effect on the reserve and response to stimulation. So in this study, they found that women with endometriomas, they had significantly lower ovarian reserve markers, the number of follicles, the oocytes, embryos, and the top quality embryos than the controls, but it did not have any effect on the clinical live birth rates, regardless of even the previous surgeries for the endometriomas. But there is a significant decrease in the reserve and also the top quality embryos. In the study, they found if the size of the endometrium is more than 6 centimeter, it had an effect, but it did not have any effect on the clinical pregnancy and the live birth rates. So this is another study in 2024 where they studied the impact of the endometriosis on the reproductive outcomes in ART cycle. They found that there was a significant decrease in the oocytes retrieved and the M2 oocytes, the total number of embryos, but the pregnancy rate, clinical pregnancy rates were lower in women with endometriosis, but live birth rate was the same. So the other effect of the surgery on the outcome in patients with the superficial or the peritoneal endometriosis. So here we know that we don't know whether the lesions are very minimal or it can extend to a larger areas. So if you are going to do a surgical excision in these patients, it may be an aggressive procedure, so there can be increased risk of postoperative adhesions. So more data is required to confirm the benefit of surgery in superficial endometriosis for improving the ART outcome, and to be able to recommend it into a routine practice, more studies are required. Now, if you are going for an endometriomas, the surgical excision, we talked about that there is a significant decrease in the ovarian reserve, and they have also studied the drop in the AMH level from 3 nanograms preoperatively to 1.87 nanograms postoperatively. That is almost a substantial decrease of 38%. And they have also studied with the unilateral and the bilateral cystectomies, and they found a reduction of 30% and 44% respectively. So considering the surgery, we should consider the ovarian reserve, all the other parameters which was discussed previously before we decide for a surgery. And there is also growing evidence that excision of this endometriomas, there is a stripping of the adjacent healthy tissue which can compromise the vasculature, and the normal ovarian tissue is found in 97% of the specimens. Even though it is done with the expertise, there is some amount of ovarian tissue which is also compromised. And unilateral cysts, they can reduce the ovulation rates in the affected ovaries from 34% to 68% in the contralateral ovaries. And there is a lower preoperative AMH in these patients with the bilateral endometriomas, and AFCs also can have the depletion in these patients. So cystectomy can decrease the AMH by 38% acutely versus 15% when you're going for an ablation techniques, but evidence supports the cystectomy because the chances of recurrence and all that is very minimal. And the repeat surgeries definitely has a deleterious effect on ovarian reserve. So it is mandatory that the first surgery is done by an experienced person, because the first surgery is going to be the best surgery for a very good outcome. And if we are planning for a repeat surgery, it should be thought twice, because it is not going to improve the fertility outcomes. So if we are planning for surgery for deep endometriosis, they definitely have the surgical excision can be offered only if the patient has symptoms like pain, to prevent rare complications like bowel occlusion or spontaneous rupture. And in those conditions, we can recommend surgery. And in a French retrospective study, they have assessed the influence of this complete removal of endometriosis in patients who do not have bowel endometriosis, and they found that it is not required to do surgery to improve the IVF outcome in patients who don't have any of this digestive the GI involvement. So surgical excision should not be performed in asymptomatic patients just to improve the outcome of an ART cycle. However, it is required in patients who are not able to tolerate pain, or after discontinuation of the medical treatment, or if there is a risk of any bowel occlusion or hydroureter or hydronephrosis. In those cases, surgeries can be planned. And the recurrence rate can be as high as 27% to 50% at the end of 24 months. And this is influenced by the age and the bilateral cysts and the ablation over the excision. So this is another article where they have found that the chances of cycle cancellation is significantly higher in the surgery group when compared to the control groups. So we should think twice before we plan for a surgery prior to ART program. So so it is better if you are planning for a freeze-all strategy, that is stimulate them, retrieve the oocytes, freeze the embryos, and then you can go plan for a surgery if it is required. So surgery might result in damage to the reserve and decrease the chances of fertility. However, all the ART outcomes, they seem to be consistently similar. So it is not recommended routinely to do surgery prior. So the current data suggests that surgery for ovarian endometriosis is more likely to harm fertility than the disease itself. So the harm of surgery is highest with bilateral and or the large endometriomas. Now, what the ESHRE 2022 recommendation is for an asymptomatic patients, if there is an incidental finding, it is not routinely recommended to perform a surgical excision or ablation, and operative laparoscopy may be considered in stage 1 and 2, as it can improve the ongoing pregnancy rate. And for an endometrioma, if we are doing a surgery, it should be a cystectomy and not an ablation or any other techniques. And preferably, it is done in patients who are symptomatic. And the studies have also shown that cystectomy and carbon dioxide laser vaporization, both of them have similar recurrence rates beyond first year. But the early post-surgical recurrence rates may be lower with cystectomies. And specific caution should be taken to minimize the ovarian damage. So if they are planning for a natural pregnancy, then clinicians can consider operative laparoscopy for endometriomas just to increase the chances of natural pregnancy, but it requires large data. So prior to ART, the clinicians are not recommended to routinely perform surgery to improve the live birth rates in stage 1 and 2, as the benefits are not very clear. So these are the ESHRE 2022 guidelines, and they also say that they are likely to have a negative impact on the ovarian reserve. So surgery is not recommended prior to ART. And surgery for endometriomas can be considered when there is associated pain, that is, the patient is symptomatic or accessibility to follicles might be a problem. In those cases, we can plan for a surgery. Just a few words about the problems which we can have during oocyte retrieval is we know that there is technically difficulty in doing the retrieval, because at times the ovaries may be behind the uterus, so it may be stuck, and we have the remote, the thing that there can be spontaneous infection, but there are some cases where they have aspirated the endometriomas. But one thing has to be kept in mind, that there's rapid recurrence of an endometrioma. Some of them have used even the sclerosing agents. So what the ESHRE recommends for a good practice in ultrasound guided oocyte pickup is the endometriomas, they should not be aspirated. Puncture must be avoided to prevent the contamination in the follicle fluid. At times, piercing an endometrioma might be the only way to avoid losing the oocytes. And if inadvertently punctured, the needle is flushed with the media and the collecting tube is changed, or a fresh needle is used. Pelvic abscess chance is less than 0.1%, ovarian abscess is less than 0.03%, and antibiotic prophylaxis is recommended. And there can be troubleshoots during retrieval, like access to the ovary requiring manual fixation. Ovaries might be stuck, so we may have to go through the uterus during oocyte retrieval. And transfixation, that is passage of the needle through the cyst without aspirating, can be one option. And contamination of the follicular fluid is another thing should be kept in mind. There can be difficulty in accessing the follicles, so incomplete oocyte retrieval is another thing which we may face in our practice. So if it is punctured, avoid contamination of the whole cohort of follicles, because we know that this fluid is going to be toxic, and it is, even though it does not have an impact on the fertilization rate directly, but it can compromise the blastulation rate and the embryo implantation rate. So the need for surgery, as per the ESHRE 2022, is the decision to perform surgery should be guided by the presence of symptoms, the age of the patient, the preferences, history of previous surgery, presence of other infertility factors, consider the age, the ovarian reserve, and also if we are doing a laparoscopy, we should do a EFI scoring, which helps in making a decision. And a word about the fertility preservation is when there is there are certain indications where we can think of fertility preservation, like in the patients with bilateral endometriomas, unilateral cystectomy with a contralateral recurrence, multiple surgeries, and at risk of, and who are also at risk of multiple surgery. In those cases, we can counsel them for fertility preservation. And also in patients with extensive endometriosis, they should discuss the pros and cons with the patient, and the true benefit of fertility preservation, it remains unknown, but still there is a hope. So we should counsel them about the option of fertility preservation. So I would like to conclude saying that surgery for endometriosis should be done only in symptomatic women suspicious of malignancy and in inaccessible follicles. And ovarian reserve testing is mandatory prior to the surgery, because it will help us in counseling the patient what is her reserve and what we can expect after 2 to 3 months post surgery. So no significant difference in ART outcome after surgery, and the options of fertility preservation needs to be discussed. Thank you very much for a patient hearing.
Shilpa madam, you have to unmute yourself.
Am I audible?
Yes, ma'am. Yes.
So that was a very nice talk, Dr. Radha Vimbu. It was in detail about the surgical management, where we should not operate. It was a good message for all of us, and also insights about how to manage during OPU for cases with endometriotic cysts was very interesting. Thanks a lot, Dr. Radha Vembu, for your presence. Can we have
Thank you,
the
ma'am.
next panel discussion? I introduce Dr. Basavaraj Devar Shetty. Can we have Dr. Basavaraj CV? So, Dr. Basavaraj is infertility specialist, gynecologist, reproductive endocrinologist, obstetrician. He's practicing at Vishwas Fertility and Gynecology Center in Marathali, HSRL of Bangalore. The doctor completed MBBS from JJM, Davangere, MD from Kasturba Medical College, and the doctor is a member of RCOG, BFS, BSOG, and KISAR, a good friend of mine. Can we have CV of Dr. Chandana Bhatt? Dr. Chandana is MS, DNB, and MCH Reproductive Medicine and Surgery, fertility consultant Bengaluru, gold medalist in MCH Reproductive Medicine and Surgery, several prizes in national and international fertility quiz competitions, won the Best Poster Award in PCOS KISAR Conference, won the National PCOS Excellence Award. Welcome Dr. Basavaraj and Dr. Chandana Bhatt for the moderation. Can we have a CV of our expert, Dr. Vandana Mishra? So Dr. Vandana Mishra is MBBS, MS Gold Medalist, IVF Specialist, recipient of Bihar Ratan Award 2024, recipient of Bihar Women Achievers Award 2021. She has done a paper presentation on negotiating cervical ores in difficult cases of hysteroscopy by a novel technique at ISHRE 2019. Guest speaker invite at Infosys Hyderabad on adolescent health. Kusum Pandit Award for the best postgraduate thesis. Poster entitled Hysteroscopy in Infertility, a pilot study presented at the Foxy FIGO conference 2017. Paper entitled Efficacy of Vaginal Progesterone Spray in Creating an Adequate Transcriptomic Signature During the Endometrial Window of Receptivity, presented at ISAR conference at Indore 2016. A research paper entitled Evaluation of Labetalol as an Alternative to Magnesium Sulfate in the Prevention of Eclampsia, presented at the annual conference of the Association of OG 2000, Delhi 2011. Indira Gandhi Award for Best Student in the Matriculation Examination 2000. Welcome, Dr. Vandana Mishra. Can we have the panelists' CV? Dr. Lavanya. Dr. Lavanya is awarded as the Women Healthcare Leader in OBGY in Asia, Foxy Award winner for contribution in OBG, invited by Taiwan Ministry of Exchange Program in OG. She is into healthcare innovations and has patent on medical devices, invited by MIT and Harvard University for medical innovation, received Dr. Balagangadhara Nath Swamiji Samaj Seva Award, felicitated by Sangeeta Mobile Limited, Hosabelaku Trust for the contributions in the field of women empowerment, received Chairman's Award for Distinguished Services, Doctors at Narayana Health, received Kempegoda Award for
I think it
Samaj.
is okay. I think the most of them know us. Thank you for
Okay.
that
That's an
introduction.
elaborate introduction that we welcome Dr. Lavanya. She's very well known in with all our friends. Welcome, Dr. Lavanya. Dr. Sapna is
Thank
not around. Dr. Vidya is a practitioner, IVF consultant at Spandan Hospital and Janani Fertility Center at Hubli, Dharwad.
you.
She's into OG in high risk pregnancies, laparoscopic and hysteroscopic surgeries. She does treatment for conditions like PCOS, thyroid disorders, and hormonal imbalance. Experience of over 30 years in the field. She's MBBS, MD in OG and FCPS, professional affiliations, member of Hubli Society of OG and Kasoga and Foxy. Welcome, Dr. Vidya, Dr. Lavanya. We have our Dr. Kavya. She's MBBS from Vaidehi, MS from MMC, worked in Vaidehi Medical College and Devraj RS Medical College as assistant professor, fellowship in infertility from Radhakrishna Hospital and IVF Center under guidance of Dr. Vidya Bhatt, fellowship in laparoscopy from Patel's Laparoscopy Center, Hyderabad, ISRM IASRM fellowship in stem cell therapy and regenerative medicine, worked as senior consultant gynecologist and IVF infertility specialist at Birla Fertility and Baby Science IVF Clinics, Kormangala, currently senior consultant IVF specialist at Milan, member of Foxy SAR Ishri IFS and RG, 4 to 5 publication in National Journal. Welcome, Dr. Kavya. This is Dr. Sujay Haranjil. He is presently content coordinator for Kosoga WhatsApp micro learning series. He's EC member of ART and Reproductive Endocrinology Committee Kosoga, past treasurer of Bagalkot OG Society, past secretary of Bagalkot IMA, working as consultant OG fertility specialist at Shirur Hospital for the past 13 years, senior resident at Father Muller Medical College and Hospital, and an assistant prof at SN Medical College and HSK Hospital, faculty at various state and national conferences. Yuva Kasuga, AICOG, Yuva Kisa. Welcome, Dr. Sujay Haranjil. Can we have CV of Dr. Priyanka? Doctor is MBBS DNB FIRM Advanced Diploma in Fertility from Germany. Current position at Consultant Reproductive Medicine Milan Fertility. Consultant OG Anugraha Nursing Home Bangalore. Her area of interest is for responders in IVF, recurrent pregnancy loss. Can we have the panel starting Dr. Basavraj, Dr. Chandana?
Yes, thank you, ma'am.
Chandana, are you screening this?
Yes, yes, sir.
Yes.
Yes, sir, you can start.
So, shall I start?
Yes, sir.
Yes, doctor.
So, good evening, everybody. So, thank you, Kasoga and Dr. Shilpa, for giving this opportunity. And see, I think our all questions are answered, and all secrets have been relieved by speakers, Dr. Prashant and Dr. Radha Madam. Once again, I will say I'll introduce. Welcome to all our panelists. And first of all, I would say endometriosis, as you know, is the most common chronic disease in the women and the reproductive age group, estimated to be around 5 to 15% of general population, and it affects around 30 to 50% of infertile women. Surgical management of endometriosis can increase the chances of successful conception. Pregnancy rate after surgery in endometriosis is nearly similar to ART. So, how does endometriosis causes infertility? By chronic inflammation and by affecting the endometrial receptivity, and it has effect on the oocyte and embryo quality, and also the ovarian reserve. So, what you're going to do now is me and Dr. Chandana. So, basically, go through 4 basic simple case scenarios, which will finish early. And Dr. Chandana, do you want to take basically what you want is you want to introduce the case scenario and ask your advice and say how you proceed with the case. Dr. Chandana, do you want to start with the first case?
Yes, sir. So this is so I would request Dr. Priyanka to just proceed with the discussion of this first case. So here is a lady, 24-year-old female and 27-year-old male, who have been married for 1 year, presented with a routine ultrasound showing a 3 into 3 centimeter right ovarian endometriotic cyst. So she is currently asymptomatic and she's not planning to conceive for the next 1 year. So Dr. Priyanka, how do you wish to proceed next?
Good afternoon, everyone, and thank you, Dr. Shilpa, for this opportunity. Though she's asymptomatic, the ultrasound is showing a cyst. So it's very important that we start with history. I would like to know that does she have, and take a little more detailed history, because symptoms specific to endometriosis, like does she have pain during intercourse? After that, I would like to go ahead with some basic investigations of fertility, even though they are not planning to conceive for the next year, because you have to explain about endometriosis and how it can affect ovarian reserve. So I would encourage her to go for an AMH test. Also, she's married, so I'd like to get the male partner evaluated as well.
So in her case, her AMH is 2.7 and her AFC is 12. So how would you, and the husband's semen analysis is normal.
Yes.
And she's totally asymptomatic. So now, suppose she asks that, doctor, when should I come next? Should I get operated? So how do we proceed in such a case?
I think I would follow her up regularly to check on the size of the cyst. I wouldn't advise surgery just for a 3 centimeter asymptomatic cyst. Patient is also not planning fertility. Regular follow-up would be necessary. Explain to her about the signs, the symptoms of endometriosis, and ask her to plan fertility sooner.
How often you
That
want to
would-
call Dr. Vidya? Can Dr. Vidya here?
Yes, sir.
So how often, Dr. Priyanka told she want to call for regular follow-up. So how often do you want to follow up?
She's not planning for pregnancy, and her AMH levels are pretty good with
Okay.
good semen analysis. I will call her after 3 to 6 months to see the ovarian size and counsel her to plan as early as possible, because the endometrioma it may change the size, it may progress also.
Any other?
Dr. Kavya, you wanted to say something?
I will call her after 6 months to just assess the size and counsel for her to plan the pregnancy sooner.
Good. I think it's fine. I think, I would say once a year would be fine. Dr. Lavanya, what do you say? Once a year would be fine, because
I think it's important that what happens if we call them after a year, patient is definitely going to be lost, and they always assume, and I'm sure if we call them after a year, we end up seeing a bigger cyst. So I would definitely agree with my other panelists saying that very important, we call them earlier at the end of 6 months, and of course ask them to report back earlier if they have a symptom. And I think it's really important that we insist that they should be planning pregnancy at the earliest and not unnecessarily delay, though the parameters are normal. I think that I would put it as the first the advice, and then call them at the end of 6 months and not a year.
Excellent.
Hi, I'm Dr. Vandana here. Can I just put a question across?
Yes, ma'am. Yes.
Yeah, please.
So I was just thinking, I think calling them every 3 monthly, 4 monthly may be too much to ask from them if they're not planning a pregnancy. And if she's not planning a pregnancy, just to make sure that the size does not drastically increase, can we just put her on some safer OCPs if she's not planning a pregnancy, so as to ameliorate her symptoms also, keep the size in check also?
I think
Lavanya, ma'am, you want to say?
Please.
What I would suggest is I think it's something very important, especially when you're putting on a hormones. It's a discussion that we need to have with the couple, because quite a lot of times we're exposing them unnecessarily to the contraception or a hormonal treatment. Of course, we know that endometriosis is not going to go overnight. I think this is why follow-up is important. But yes, certainly, I think if we tell them, and anyway, we know that their plan is to conceive only after a year, we can tell, buy these pills for at least, not that all medicines would reduce the cyst or keep it at the same level. So it will have an additional contraceptive effect. Yes, definitely, this is something that we could be offering to them. And I think it's something that we need to do it with the consent, but not put it as one of the modalities of treatment. It's an open discussion.
Correct. So we can offer it to the couple. Correct. Thank you, ma'am.
So I'll go to the second case scenario. So 30-year-old female and 35-year-old male married for 18 months. They plan to conceive. And the woman is presented with severe dysmenorrhea and menorrhagia. And an ultrasound scan, so it shows an endometriotic cyst in the left ovary measuring 4 into 4 centimeter. And so Dr. Sujay, can you just tell us what are the fertility options available for them when they come to you?
Sir, Dr. Sujay is stuck in an emergency, so that's why.
Okay. I think Dr. Kavya, can you take over this case?
Yes, sir. First, we'll do a detailed evaluation of her, do an AMH, and since she is severely symptomatic, and male factor also will be checked, and 4 into 4 centimeters endometriotic cyst, and how we'll assess in ultrasound how is movement of the ovary, whether it's fixed or anything like that. If we feel that it is extending, and then we will plan a diagnostic laparoscopy in order to grade the endometriosis also. That also can be offered.
Okay. So, so any option of IUI in this scenario? Do you want to consider IUI in this scenario?
We will check the tubal status in the laparoscopy. If tubes are okay, if it is grade 1 or 2 only, just isolated with the ovarian tissue and not it's not, there is not a lot of adhesions and all, then IUI can be offered, sir.
So I am asking you pre-operative, before going for surgery, do you want to consider going for IUI is an option?
Tubes must be checked.
So, Dr. Vidya, any
status
differential?
must be checked before.
It's just 18 months of marriage. If it depends on her AMH level, whether I will go for IUI or surgery.
And AMH is normal. AMH is 2.4.
Then I will give them to both the options, going for surgery or trying for IUI. Because some patients, if you give only surgery option, they will vanish. They will never come back. So I will keep the patient if they are willing for IUI with HSG. I will do the tubal status and proceed with IUI for. I will give you them 2 or 3 cycles only, and then I can mobilize them better for surgery if they are not conceiving. If they are ready for surgery and her AMH is less, then surgery is the good option.
I think it all depends upon our discussion with the couple. Some couple would like to go, would like to avoid to go for surgery. Some couple would like to go for ART surgery and IUI. So I think it's all depends upon our.
Can I too much knowledge on the medias that surgeries with endometriosis, they will decrease their ovarian reserve. That things they are reading, so they are not getting ready for surgery all of a sudden in one settings only.
No, I feel, because the couple are young and all the parameters of AMH is less. I'm sorry, I didn't hear if the semen analysis was normal. Assuming that semen
normal,
is
ma'am.
normal. Yeah, so if assuming semen analysis is normal, AMH is normal, 30 years, married for 18 months. Only if the symptoms are really bad, of course, I see that you've written it as severe dysmenorrhea. I think 2 choices can be given, that we go in, put the scope, we see what could be done for them. And simultaneously, if you're doing only a surgery, then you do the tubal evaluation. But majority of the patients, endometriosis, unlikely that the tube would be blocked. Majority of the times we see that in endometriosis, tubes are going to be patent. We can give them both the options simultaneously, that we could certainly do an ovulation induction and try either a natural cycle. We all know IUI will increase by another 5 to 10% of our chances. So we could be trying 1 or 2 cycles. And if it doesn't work, maybe the second option I would put as a surgery. Though I'm a surgeon, I think I would still keep that as the second line of management. But until unless she really complains and her pain score is 10 on 10 or 9 on 10, then I think surgical modality will be a better modality to go ahead. But otherwise, I don't think tube should come even before we even start 1 or 2 cycles of an ovulation induction, is my opinion.
I think it's all depends upon the patient choice, actually. We have to discuss with them. So what does the evidence says? So operative laparoscopy could be offered as a treatment option for endometriosis with stage 1 and 2, as it improves the ongoing pregnancy rate. Clinicians may consider operative laparoscopy for treatment of endometrium-associated fertility, as it increases the chance of natural conception. So again, surgical removal of endometriosis lesion reduces local and systemic inflammation and improves fertility. Adhesiolysis is very important, as it helps to restore normal pelvic anatomy and also negative impact in fertility. Surgery has been shown to reduce the ovarian reserve, with only benefits of this approach would be to improve the symptoms and also for the accessibility during the oocyte retrieval. So again, as Dr. Radha Madam told that, once again just will go through the surgery for endometriosis. If there is severe symptoms, pain is the main symptom. Second is the age. If the young woman, better to go for surgery. And patient preference is very important. History of previous surgery, tubal factors. Again, most important among this is antral follicular count in AMH, and also to see whether if we are proceeding for IVF and it's quite difficult to access the ovaries, we can consider surgeries. So I think we'll take the summary of that is, I think it depends upon the patient preferences. Young women, normal semalysis, normal fallopian tubes. I think if the patient accept that, okay, she would like to go for 2 cycles of IUI and surgery followed by IUI, it's so followed by surgery, or she can consider surgery and trying for a couple of months followed by IUI. I think it all depends upon the counseling between the doctor and the couple. Chandana, we go to next case.
Yeah. Yes, sir. Dr. Kavya, I would like you to answer this. A 36-year-old female and a 40-year-old male, married for 5 years, desirous of conception, presented with an ultrasound showing a 2 into 2 centimeter bilateral endometriotic cyst. She is currently symptomatic, and she also gives a past history of undergoing endometriotic cystectomy 3 years ago. The HSA is normal. So how do we proceed next? Do we offer her surgery? What do we do?
For this case, we don't offer the surgery because it's
You're not
very
clearly
small,
audible, Dr.
2
Kavya.
into 2 centimeters. We will check her AMH. Can you hear me?
Yes,
Yeah.
no, yes.
Can you hear me now?
Yes, yes.
So since she has already underwent a past history of cystectomy and now the cysts are very small, we won't offer her surgery. So we will counsel her for IUI.
But currently
accept
also she is
induction.
symptomatic. So what benefits or what harm does surgery do for her, if at all you do a surgery for her?
It is a very small cyst and it is bilateral. So you're not going to offer her major benefit from the surgery. So since she's desiring conception, we should proceed with 2 cycles of IUI and then proceed further.
So before considering
I think,
IUI, yes,
my approach would be that I would counsel them for IVF. Bilateral cysts, already surgery has been done. Definitely wouldn't offer surgery again. Considering her age, I think it would be better to go ahead with the IVF itself.
She's only 36. No, she has not tried any other treatment.
I know,
So
but
at least
her marriage
can be
is
tried
5
at
years.
least 1 or 2 cycles.
No. Her
I
marriage
think
is
all of
5
us,
years.
ma'am, considering that already she's undergone surgery, I would suspect I wouldn't really be sure about her tubal status and how beneficial IUI is. Planning IVF would be better, I think. I mean, it would give her a better chance. Husband's analysis is also normal.
At the AFC is good. I think they can consider going for IUI 2 cycles. There's nothing wrong. I think it's just a counseling.
It depends on her AFC and AMH.
Yeah.
How to go ahead. If her AFC is good and AMH is good, I will definitely tell her that you are 5 years of marriage life. That means 5 years of trial is there, and one cystectomy is done. IVF is the best option, but I will not deny for IUI also.
I think the major history of missing is they're married for 5 years. How long have they been trying? I think is something very important.
Yeah.
So, I think if AMH, FSH is, AMH and your
not given the AMH. We wanted to address this question. That's the reason we put it there.
Yeah. If AMH is good, I think, And considering, I think we should remember that endometriosis is something very recurrent and we can't keep operating and, of course, there's no point of surgery for her. 1 or 2 cycles IUI and definitely sooner the IVF, better.
We should discuss with them what is the exact success rate of IUI and IVF.
And directly, sometimes when we directly counsel them for IVF also, they may not be willing because they have not tried anything which is given for fertility treatment.
So we put this case
5 year surgery already done. That means she had undergone something.
No, ma'am, fertility treatment has not been done. No? So 1 to 2 cycles at least IUI can be offered. And then if
See, the case why we put it is here is basically we didn't put that she has been trying. She has been married only for 5 years. Okay, we didn't put we wanted to ask you the question that how long she has been trying, and we wanted to ask you what is the AMH. That's the whole purpose of just a scenario, just to change the scenario in this case.
Yes.
Vandana ma'am, you want to comment anything on what we've discussed so far?
I think we all have discussed the most important things. One is very important to know how long have they been trying. So that is important. We do not know her exact AFC. If that is poor, then madam is right that it would be wise to her to know that the success rate of IUI given her endometriosis conditions besides her age, the success rate of IUI may become very low, and later if she delays IVF, going ahead with her self-ex may also become a difficulty. So IVF would be the first choice because of her one age beyond 35 and bilateral endometriosis plus a cystectomy prior. So definitely her egg reserve would be a little on the lower side versus a female of 36 years old without endometriosis. So first option, I would offer her IVF if she's really scared and not willing, 1 or 2 cycles of IUI, only if the tubes, at least one is patent.
So the gist is we need to check for how long she's been trying, what is her AFC, what is the semen parameters are normal, and then counsel her regarding, what are the pros and cons of either trying 2 cycles of an IUI provided everything is normal or going ahead for an IVF.
Correct.
So what does the evidence say regarding a repeat surgery? So for any hormone treatment or surgery can be offered to treat recurring pain symptoms in women who have endometriosis, but definitely not a repeat surgery for enhancement of fertility. So coming to what are the factors which favor surgery and what are the factors which favor ART, especially in a couple who present like this. So who basically don't have any previous prior interventions for endometriosis, whose ovarian reserve is normal, they are symptomatic. It's more of a unilateral disease, and the ultrasound is showing us some atypical features, and it's a rapidly growing endometrioma, and it's a shorter they present with a shorter duration of infertility, and of course the patient's choice, we go ahead with surgery. But if the reserve is poor, she's totally asymptomatic, it's more of a bilateral disease, something like our patient, and there are no other atypical sonological features on the ultrasound, and it's been a stable growth, and it's a longer duration of infertility, though all these factors favor ART.
I think this is the last case scenario what we're discussing. 37-year-old female, married 42-year-old male, and they're married for 3 years. And she now has come to the first time for the investigation and found to be 7 into 7 centimeter right endometriotic cyst with husband with normal seminal analysis. So how do you proceed?
Definitely operative hysterolaparoscopy.
Before that, you want to do anything? The whole purpose is, I think we have to evaluate other factors before, directly help a surgery.
Yeah, AFC and AMH first.
Okay.
So day 2 day 3 ultrasound AFC, and also to check how accessible her ovaries are, because she's got a 7 centimeter cyst.
Sir, AMH is 1.2. Our AMH is 1.2. So what you want to do?
Considering size of the cyst is big, and consider surgery here. But of course, we have to counsel the patient about her ovarian reserve and post-surgery, how it can get affected also.
So at this point, I think I would like to give my input and open a Pandora box here.
Yeah.
Two Pandora boxes I can actually open. I think 7 into 7 centimeter, considering her age, considering her AMH, everything, of course, assuming all the husband semen parameters, everything is good. And definitely, I would still say surgery is a better modality of treatment for her. We're talking about surgical, different modalities are different, but of course, surgery is something that's very indicated. If we are operating, I would prefer that we can do a stem cell for her, not because of her AMH being 1.7 or so. I think the newer study is something that it will come up in the future would be something where the stem cells have started working, and they're collaborating with one Cambridge University as well, where stem cells has been, because I think we all know endometriosis is something with pro-inflammatory. And that is why we end up having always the quality of the oocytes can be altered. The number of blasts are much lesser. So stem cell will be one of the treatment modalities. Like I said, of course, this is just initial studies we are at. where the inflammations can come down. This is not done for increasing your AMH, but it reduce the inflammatory cytomarkers. So while you're operating, I mean, I'm a robotic surgeon, so I would definitely say at this point, robotic surgery would be easier. But of course, depends on what do you have. A good laparoscopic surgeon is always better. If you're not a qualified laparoscopic surgeon, please send it to them, so that just aspirating the cyst and coming out is not going to help, because it's going to be refilling even before you start a treatment modality. So you have to do a cystectomy to make sure that the recurrence is much lesser. You've done a clean surgery so that you can go ahead with your IVF would be a better modality for her.
Any other views?
Lavanya madam, these stem cells were injected. Where they exactly will inject those stem cells?
So we inject it into the ovarian cortex, where once you've done a cystectomy, so you do it on that surface of that where you've removed the cyst.
Okay, the same ovary.
Yeah.
Okay, thank you.
The other approach I would suggest, basically, when you're going for laparoscopy and the AMH is very less, and we don't have the expertise of the stem cells and all, would it be good to go for laparoscopy? Not the cystectomy, that puncture it and aspirate the cyst. Then basically you're looking for not for the pain, mainly for the accessibility, the difficulty in accessibility.
No, anybody. I don't think cyst aspiration is something is a no, absolutely no. That's why I said,
you open it and basically it's not the puncture, basically, because you don't want to do cystectomy for 1.2 with a big cyst with a large endo. You're going to reduce the antral follicle count. So you're already discussed the patient that you would like to go for IVF.
Can we do? Can I add? Put my point through?
Yeah.
Yes. So many a times we have seen, like most of us would have seen a 7 centimeter or a larger endometriotic cyst. And if it is not falling in the path of our needle, we can go ahead, do her embryos freezing, and then do a laparoscopic cystectomy, give her a 3-month rest with down regulation, and then do a ET. So I would do that.
Yeah.
If it is not falling in the line, and most of the times it is possible to aspirate the oocytes and not going through the cyst also, because we have seen that the cysts are mostly like posterior, the follicles are in the periphery of it, and we can do the aspiration safely, and we can leave a few follicles if it is actually coming in the way. If we are really scared, we can do the embryo freezing, do the cystectomy in the subsequent cycle, and then give her a down regulation of 3 months, and then do a ET later on.
Yeah, the only if it comes on the way of the
cystectomy before the follicles are aspirated. That would further reduce her AMH and her egg reserve. Unless it is falling in the path of the cyst or follicles.
Does anything helps with that, Lavanya? Anything helps with the robotic in this scenario?
Definitely, because I think it's just that majority of the people wouldn't be accessible to robotic. Just for a discussion's sake, I would say robotic is definitely better for at least severe grade 3 and grade 4, not at least if not grade 1 and 2. Grade 3, grade 4 robotic is always better, because I think we need to remember we have a 10 times more depth perception. Magnification is also much more better, and the delineation of the normal tissues and the abnormal tissues are going to be way better. We've also published an international study between lap and robotic endometriosis of grade 3 and grade 4. Recurrences with the robotic surgeries being least. And of course, even through laparoscope, because we've been doing laparoscope for decades together, recurrence is lesser, but comparatively robotic is way lesser. And normal tissue preservation is more better in robotics, so that you don't have to be worried about reducing your AMH further down.
Excellent, Lavanya.
If the laparoscopy surgeon is skillful enough,
yes, definitely.
there is no
that's why I said, referring to a laparoscopic
or calling
surgeon
the
is
doctor
important.
to our hospital is also a good option, no?
Yes, definitely. That's why I said endometriosis, I think, has to be always done by somebody who's more skillful, so that you need to be concerned about the patient where they don't have to end up in a recurrent surgery. I think that should be the motto while we are touching on endometriosis.
So the next slide, Chandana. So what is, I think it has been well told by Dr. Radha Madam actually. So surgical management of ovarian endometriosis can be effective in treating the endometriosis associated pelvic pain and infertility. There is no evidence that surgery for ovarian endometriosis increases the success of IVF. Next slide. I think these are the slides that which have been. I think the two procedures which we want to discuss is one is ovarian cystectomy and another is a coagulation. I think both have been discussed in detail by Radha Madam. Basically, in ovarian cystectomy, the recurrence rate is less, but you are going to damage the normal ovarian tissue. Whereas in coagulation, so basically, the recurrence is high in electrocoagulation. So we should not do medical, when not to do medical management endometriosis. One is asymptomatic patient, one who is planning to conceive and following surgery, especially when they're planning to go for fertility. So what is the effect of endometriosis on oocyte quality? So there is a high level of ROS in patients with endometriosis as a result of altered iron metabolism, leading to high level of iron, ferritin, and hemoglobin in the peritoneal fluid. With endometriosis. This has a negative effect on the oocyte quality and ovarian reserve, result in oocyte aging, which results in impaired implantation and early embryonic development. And we should note one point that women with severe endometriosis, they have a high risk of early pregnancy miscarriage. So I think this has been discussed in the last speaker. So basically, what are the advantages of expected management and surgical management? Next slide, Chandana.
So just a few thoughts on elagolix in fertility. So elagolix is basically a drug, a nucleotide in the block, which has been used mainly for the management of pain in endometriosis. But this drug, as nicely elaborated by Dr. Prashant, this is not a drug that has to be used in infertile patients. So it is not something which right now people are even suggesting or they're comparing Dynogest with dydrogesterone and telling that dydrogesterone can be used as an alternative to Dynogest because women can conceive even on dydrogesterone. But unlike this, elagolix cannot be used in infertile women planning pregnancy who are anxious to conceive. So this is the message that we want to give. So these are basic. This medication is only for women who are symptomatic, who have progestin resistant disease, who have side effects from ocipils and have not responded or have intolerable side effects with the first line treatments. So we just want closing comments to start with, first from Dr. Lavanya ma'am, Vidya ma'am, Kavya and Dr. Priyanka, and finally from our expert. Lavanya ma'am first, please.
Yeah. First of all, I think I would like to congratulate Dr. Chandana and Dr. Basvaraj, wonderfully moderated. We really enjoyed the discussion and great interacting with my panelists as well. Thank you, Dr. Shilpa and Kasoga. I would say do not touch the endometriosis unnecessarily if it's not troubling you. And go by conservative management. If she's young, AMH good, AFC is all good. Conservative with ovulation induction IUI and then only for an IVF until unless indicated.
Thank you, ma'am. Vidya ma'am.
Thank you, panelist and Shilpa madam. And thank you, the Chandana and Baswaraj sir. I would say that if you really want to go ahead with the surgery, you assess the patient, whether she needs surgery or not, and take it done from a good skilled laparoscopic surgeon only.
Thank you, ma'am. Dr. Kavya. Closing comments. Dr. Priyanka.
Thank you, Dr. Basavaraj and Dr. Chandana. I would also like to say the same thing that we discussed during the panel, that counseling is important, giving patient information. Sometimes it might be the patient's choice. They'd like to do one cycle of IUI before going for IVF. Also, like it was mentioned by Dr. Vidya, expertise, if it is available, it's okay. Otherwise, repetitive surgery for endometriosis may only bring down the ovarian reserve. But at every point of time, I think counseling plays a very important role.
Thank you, Dr. Priyanka. Now we have the closing comments from our expert, Vandana ma'am.
Right. Thank you, Dr. Chandra, Dr. Basant. Thank you so much. Thank you, Dr. Shilpa ma'am, for giving me this opportunity to be amongst you all. And it was a pleasure. And I don't think I have anything much to add beyond that. If at all we are doing a laparoscopic surgery, let it be by the hands of a gynecologist rather than by the hands of a surgeon. So I think that is very important. I don't know in that part what happens, but I am from Bihar, Patna, practicing over here, and many of the times it is done by general surgeons. And I have seen like the surgeons, they would generally do a cystectomy only, or would be very generous by removing the entire cyst, regardless of how much damage to the ovarian tissue they are doing. So that is one thing that we
Some
as
surgeons are
gynecologists.
removing entire ovary. I have seen people removing entire ovary.
Correct,
Very
correct, madam.
generous.
They
So I
want
thought it is
the
happening only in this part.
treatment.
So this is very important. Like us gynecologists should be there, or else we should be trained enough to do it by ourselves. So that is one important thing. Rest everything has been discussed so clearly, so lucidly. Thank you so much.
Thank you, ma'am. So, finally, to conclude, endometriomas are associated with reduced monthly fecundity rates, although a direct causal relationship has not been well established. Endometriomas are known to impact the ovarian reserve, and women in the reproductive age considering surgical treatment should have their ovarian reserve parameters assessed before surgery. The surgical management option of a cystectomy, drainage with adjuvant therapy such as coagulation or sclerotherapy should be individualized. Repeated or extensive ovarian surgery can have a detrimental impact on the ovarian reserve. Surgery may reduce the endometriosis associated pain. The theoretical benefit of performing a surgery to improve the pelvic anatomy and accessibility is plausible, but has not been supported with substantial scientific evidence. And surgery can be used as an adjunct to aid fertility treatments when transvaginal access of the ovaries for egg collection is suboptimal and is likely to impact the IVF outcome. Finally, the management decision should be individualized and based on patient's choice, age, ovarian reserve, and associated symptoms. Thank you.
So that was a short and crisp brainstorming panel discussion from Dr. Basavaraj and Dr. Chandana Bhatt. Hearty congratulations. And the wonderful panelists. Really, the discussion was very good. He brought out all the dilemmas that we face during our practice and how we have to finally give the best to our patients. Thanks a lot to all our speakers, all our panelists, our expert, Dr. Vandana, and the whole Kasoga family. Thank you, everyone. Thank you, everyone, for your time.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, ma'am.